So welcome to Guy Talk, a men's sexual health after bladder cancer patient insight webinar from the Bladder Cancer Advocacy Network. We'd like to thank Bristol Myers Squibb, the EMD Serono Pfizer partnership, Fairgene, Genentech, Merck, Photocure, and Urigen for their support of the Patient Insight webinar series. My name is Stephanie Chisholm, and I'm the Director of Education and Research at BCAN. After a bladder cancer diagnosis, the conversation about how to live your life fully following treatment often doesn't always occur. Sexual dysfunction is a common phenomena after many bladder cancer treatments, and yet sexual health is often overlooked by patients or their doctors. And there may not be a lot of discussion that really addresses the impact of various sexual changes that happen as a result of bladder cancer treatments. Things that might impact your sexual desire or libido, your sexual function, your body image, or even intimacy between partners. And we're really delighted to have Dr. Andrew Matthew, a senior staff psychologist at Princess Margaret Cancer Center in Canada, with us today. Dr. Matthew will provide insight on current research and answer your questions about preserving or restoring sexual function after bladder cancer treatment. Dr. Matthew is a clinician investigator in the Department of Surgery, Division of Urology, and co-lead of the Genital Urinary Survivorship Program.
Well, hello, everyone. And
yes, it looks great.
All right, super. So hello, everyone. And I just want to say it's a real pleasure to be here today to talk to the Bladder Cancer Advocacy Network and to be invited to speak here. I was hoping it would be in some exotic location where we could all be together. But unfortunately, that's not the case. So instead, I'm in my son's bedroom in Toronto, Ontario. I'm wearing a nice press shirt, but I am wearing a pair of sweatpants. I guess there's one benefit to this, to the Zoom meetings. Anyway, I very much appreciate the title of the talk today, and I look forward to speaking to you about men's sexual health and bladder cancer. And let me just see. There we go. So outlines, I'll talk just a little bit about myself again, but I thank you very much, Stephanie, for a wonderful introduction. Then I'll go on to do a brief discussion of Bladder Cancer 101, impact on health-related quality of life, and then really get into the meat of the talk where we'll talk about the physical nature of sexual dysfunction. I'll also talk about body image and sexual health given its prominence in bladder cancer, and then as well, the psychosocial nature related to bladder cancer and sexual function. So here you see a couple pictures to the right. I'm a psychologist. I've been actually at Princess Margaret Hospital in the Department of Genital Urinary Cancer. So my responsibility is the psychosocial well-being of cancers who've been diagnosed with prostate, bladder, kidney, and testicular cancer. And I've done that for about 25 years. And in doing so, I really did recognize that there was a gap in care where many of these cancer sites and patients and partners suffering these cancers, the diagnosis and treatment of these cancers, were experiencing sexual dysfunction, and there was very little care offered. I then developed a face-to-face clinic in the hospital, and then again, this was specific for prostate cancer at the time, and then it's now expanded to bladder cancer. And then Movember actually got in touch with me to create a sexual health and rehabilitation clinic for prostate cancer online, and I developed a shared clinic. I've now just requested to get some funding to see if I can now make the similar program for bladder cancer, so fingers crossed on that. As well, you'll see that luckily there's some real initiation in the healthcare system to recognize that this is a gap in care. In Ontario, we have an organization called Cancer Care in Ontario that structures the funding for cancer care in this province, and it has association with other agencies at other provinces across Canada. They specifically requested that we develop some guidelines. And so here you can see the quality initiative, interventions to address sexual problems in people with cancer. And I work closely with a multidisciplinary team to develop that guideline. So I have a real interest in supporting patients and partners as they go through this. So bladder cancer 101, I think most of you are very much aware of this, so I won't take a long time. The fourth most common cancer in men. The American Cancer Society estimates about 83,000 new cases, 64,000 of which are men. In 2016, it's estimated about almost 800,000 urinary bladder survivors in the US. So you can imagine both the US, Canada, and worldwide, there's a huge population that are surviving after treatment, which is wonderful, but also living with the quality of life impact and in particular, likely some levels of sexual dysfunction. And hopefully we can do better at treating the sexual dysfunction. Men are 4 times more likely to be diagnosed with bladder cancer. And then more than about 70% are diagnosed with non-muscle invasive disease. About 30% will progress to muscle invasive disease. And in about 4% of cases, it's spread to distant parts of the body. This just kind of helps orient us for our talk today. You can see here, I don't know if my mouse is actually visible, but right in the center, kind of a rouge colored oval is the bladder. Just beneath it, there's a gray section. That's the prostate. That's the urethra going through the prostate and exiting. And here, as you see the testicles, these are the seminal vesicles just above the prostate adjacent to the bladder. And that'll give you some idea as we continue to describe the impact of treatment. Staging, I'm sure many of you are also familiar with this. Probably the ones you most recognize are carcinoma in situ, which is on the surface of the bladder wall. And then we move on to superficial muscle invasion, deep muscle invasion, and then distal spread. So as I said, the majority are non-muscle invasive bladder cancers. The treatments associated with, I'm just gonna close that. The most common treatment is the TURBT, which stands for transurethral resection of bladder tumor. This same procedure is often used to find out if someone has bladder cancer, and if so, whether or not it is muscle invasive. TURP is also most common treatment, often referred to as scrapings. That's the physical scraping of the tumor off the bladder wall. And on occasions, tumors may be burned. It's called fulguration, or cancer cells can be destroyed using high energy lasers. In terms of muscle invasive bladder cancer, representing about 30% of bladder cancers, there is such a thing as partial cystectomy. It's quite rare, just mainly because most people's cancer is not contained enough in a localized area where we can just resect a certain part of the bladder and then restore the bladder. So it's quite rare. What is much more common is radical cystectomy. And the operation removes the entire bladder, the entire prostate, and the seminal vesicles. And that's, as you will see, very important to recognize if we're taking a look at the potential impact of the treatment on sexual functioning. As well, most of the time, chemotherapy is given before cystectomy is done, usually BCG. If someone undergoes a cystectomy, it requires some kind of reconstructive surgery. They're basically separated into two groups: incontinent diversion and continent diversion. On the left here, you see a continent diversion that's often referred to as an ileal conduit or a urostomy, and we have an ostomy and an external pouch. Then we have a continent diversion that refers to an ostomy and an internal pouch. And the urine is actually released from the internal pouch by catheterization through a stoma. And then finally, continent diversion, where a bladder is created out of the intestine, and this is called neobladder. And so I know that many of you are probably very much aware of this, and it's also important to recognize that when we're taking a look at the impacts of sexual dysfunction, if we take a look at the issue of body image, when we then taking a look at ileoconduits, or where we have an ostomy and an external pouch, or or an ostomy in an internal pouch, and the ostomy patients can complain of having body image concerns. In terms of a neobladder, those concerns are obviously, the body image concerns are obviously less apparent. However, the ongoing care for a neobladder and the systematic approach of caring for and utilizing the neobladder can be challenging for patients and emotionally challenging as well. Other treatments for muscle invasive bladder cancer include radiotherapy, and then chemotherapy can be used in terms of adjuvant therapy to shrink the tumors before surgery, or shrink the tumors, and actually enhance radiation prior to radiation. Or if we have distal disease, then some systemic therapies known as the broad-based chemotherapies like gemcitabine. So when we take all of this together, and we want to take a look at the impact of health-related quality of life, and it is true, although there's a certain recent uptake, which is great, there's not a lot in the literature specific to bladder cancers, the types of bladder cancers, the types of different treatments, the types of reconstructive surgeries, and really kind of differentiating each of those and providing us real insight into the health-related quality of life specific to gender, type of treatment, type of reconstructive surgery, and the like. So there's certainly more work to be done. But overall, these are the big domains: urinary problems such as frequency or leakage, sexual dysfunction, body image, fatigue, pain, psychological impact, certainly anxiety and fear, and depression. These are they're the common fears that come with many of the cancers, and that's things like fear of recurrence, fear for future health, fear of one's mortality, but also more specific ones related to the experience of bladder cancer. If, for instance, someone has had a cystectomy and reconstructive surgery, they can have concerns if it's depending on the type of surgery. There's concerns about travel and an ostomy and bag or pouch care and the like. So there can be a real reduction in the everyday quality of life. And then another very common one and challenging for people is social isolation. But if you note here, and this is actually probably described as weighted or rank order in which these patients are reporting impact on their quality of life. So you can see sexual dysfunction, and we'll also talk about body image, ranks very high in terms of the overall impact on quality of life, and hence the importance of this topic. Conservative estimates for men is about over 50% will experience sexual dysfunction in relation to their bladder cancer and the treatment. About 50% experience bother. So if it wasn't bothersome and there was experiencing some dysfunction, that's okay, but there is real bother. And when I say real bother, I did research in this area, and they would describe this as being moderate to severe bother. When I've been doing psychosocial research in the entire trajectory of the disease and the diagnosis of being of any cancer, the most common range of distress is usually mild to moderate. It's relatively rare to get moderate to severe. So not only is there dysfunction, but there's significant bother. And as well, up to 70% can discontinue sexual activity as a result of their sexual dysfunction related to the bladder cancer and its treatment. And this is very important. You can see here, sex is part of a quality of life, and sexuality is lifelong. 57 to 64-year-olds, you can see 73% are sexually active. If we go down to the last age group there, age 75 to 85-year-olds, or 26% are sexually active. Half of this older group reporting frequency of 2 to 3 times a month. And so, as you can imagine, after doing this research and making this slide, I immediately brought this home to my wife, but unfortunately to no avail. So we'll just go to the next slide. So when we talk about sexual dysfunction, obviously, oftentimes it'll kind of immediately go to something like erectile dysfunction in men. But sexual dysfunction is broad, and certainly erectile dysfunction plays a major role in this group. But it is important to identify the nature of sexual dysfunction. We take a look at loss of ejaculate, erectile dysfunction, loss of penile length, body image concerns, loss of libido, impact on masculinity, sexual performance anxiety, and its overall impact on relationships. I know that given this is guy talk, I imagine there's mostly men online today, but if there are female partners online or male partners online, you're very welcome, and recognize that I'm focusing mainly on sexual dysfunction and mainly in a physiological way, but I'll work on the psychological. And the idea is that that sexual dysfunction in any single individual has a significant impact on their partner, not in necessarily the negative sexual ways one think, but the idea that that it can have a negative influence on relationships. And so it's very important to work through this as a team, and I'll get to that point later on. Anyway, from this point, I'm going to go through each of these and talk more specifically about them. So loss of ejaculate, that really is a physiological response to treatment. If you're having a cystectomy, as I mentioned before, there's the removal of the bladder, there's the removal of the prostate gland, and there's the removal of seminal vesicles. Under those circumstances, if you see here, this is the prostate, if my arrow is working, that center kind of walnut shape there. It's about the size of a walnut, actually. And here's the seminal vesicles. The sperm actually enters in here. Then the prostate, which is a gland, releases a significant amount of fluid. This fluid is designed to carry the sperms out during the orgasm or during ejaculation, and the sperm. And so what you see in ejaculate is significantly made up of the prostate gland fluid and not sperm itself. So it's mainly, the semen is mainly made up of the fluid released by the prostate gland. And so when the gland is removed during a cystectomy, that is why you'll end up experiencing what we call dry orgasms. You still have the sensation of having an orgasm, but it comes without any ejaculate. And just so you know, if there is sperm present, it's usually just absorbed by the body or retrograde up into the bladder, and you won't see it at the time of orgasm or climax. Then the bigger topic, I guess, is erectile dysfunction. Before I get into the treatments, just to quickly look at exams and treatments. There were some questions that were received earlier on and comments about the potential for erectile dysfunction in response to cystoscopic examinations. It's not common after cystoscopy. It's likely probably due to the practical manual manipulation during cystoscopy that causes discomfort related to the procedure. And this may make the whole region, the genital region, to feel sore, and that may have some kind of psychological impact to create the erectile dysfunction. It can also lower desire just because there's a lot of focus on that area and there's disruption during that examination. Then there's the TURBT. It can interfere with sexual activity just merely because after scraping there's a lot of bleeding and discomfort. So there are often a period of time where people are just not interested in engaging in sexual activity. There is some scientific research going on to see if there is if we can take a look at TURP as causing some level of erectile dysfunction beyond the bleeding and the discomfort, and they're examining of that, although the evidence is certainly not fully in. But there is a possibility that the energy from the burn or the laser could reach the nerves and disrupt the nerves, and hence have a physiological effect that could cause some short-term erectile dysfunction after a TURBT. As long as the nerves aren't severely damaged, they will restore function. And then there's the addition of BCG. Again, sexual activity is interrupted during treatment, as it's not suggested to engage in sexual activity during this time. Also, the impact of fatigue and flu-like symptoms, so you're just not interested in engaging in sexual activity. And then we have radiation treatment. There is reporting that patients can experience erectile dysfunction after radiation treatment for bladder cancer. It's certainly it's not as common, and certainly not as common as you see in terms of, for instance, prostate cancer. And that's merely because the area of radiation is focused up on the bladder for bladder cancer. And as long as the field doesn't reach down far enough to encompass the prostate and the nerves that go down either side of the prostate, then hopefully the erectile functioning will not be a result due to injury of those nerves. Unlike radiation in prostate cancer, as I said, where the actual field of radiation is directed right on the prostate and certainly hits the nerves responsible for erectile function. When we think about erectile dysfunction in bladder cancer, I think many of you would recognize that this is often very strongly associated with a cystectomy. And that is, as mentioned before, it's not only that we remove the bladder, but you actually receive what's called a prostatectomy. And oftentimes nerves responsible for erections can be damaged during a prostatectomy. Here again is a diagram. If you can see my arrow, this is the bladder, this is the seminal vesicles, this is the prostate here, and the urethra heading on out. And these little tiny nerves are fused to the side of the prostate, and those nerves are responsible for erectile functioning. And so they run down either side of the prostate. And as you can see, they're not like cables, they're actually microscopic and almost like mesh-like, and they're fused to the side of the prostate. And so during surgery, those are, for lack of a better description, filleted off the prostate and hopefully left intact, and the prostate is removed. If, however, that's not available, sometimes those nerves can certainly be damaged and cause erectile dysfunction. Also, it's important to note those nerves are responsible for erection. They're not responsible for sensation on the penis. So this procedure should not interfere with the tactile nature of sensation on the penis. In other words, your penis will have the same sensation on the shaft and the head of the penis, even without the nerves. The factors that, one other point is loss of penile length. There is a loss of penile length. That's just due to scar tissue and some disruption of blood flow and the like. But what it really can be seen as that there's the prostate's removed, the urethra needs to be pulled up and restored, connected. And when it does so, the penis is pulled in a little bit. This was something that I had known about for a long time. What is interesting is that no one had actually checked out whether this shortening penile length lasted forever. And there's optimistic research that the penile length can restore itself, usually at about 1 year post-treatment. Factors that influence the level of erectile dysfunction that people experience post-surgery are nerve sparing status. As I said, the nerves run down either side of the prostate. And you can have bilateral nerve sparing where both sets of nerves are spared, unilateral where one set of nerves are spared, or non-nerve sparing where unfortunately in the removal of the prostate and the bladder, the nerves were also removed. Other things like pre-treatment erectile functioning. If you had erectile problems prior to treatment, this will certainly disrupt it even more. Age, younger men have a better chance to recover of function. Comorbidities, especially cardiovascular conditions, can disrupt return of function, and also waist and girth, or rather waist girth, and that's just a practical aspect of the degree to which the surgery itself is performed, when performed, it's easier for the surgeon the more slender you are. We have lots of proerectal agents and devices that are useful or helpful. Oral medications like Viagra, microsuppositories like MUSE, vacuum device, intravenous injections, and penile implant, all of which have varying but positive influence on proerectile therapy. I'll go through each of them. The most common one you'll know of is the PDE5 inhibitor or oral medications. The four that are most commonly known are Viagra, Cialis, Levitra, and Staxim. They're just two different modes of application. They're both pills, but one is taken sublingually. The other is Sendra. And they often prescribed in two ways. One as needed. So follow your doctor's prescription. The maximum dose for Viagra, say, is 100 milligrams. Sendra is 100 milligrams. It can go up to 200 milligrams. Cialis is 20 milligrams. Levitra is 20 milligrams. And it doesn't mean that Viagra is significantly more powerful than Cialis. It's just that they're calibrated differently and given out at these milligram weights. The daily dose, the one most commonly used for that, is the 5 milligram Cialis, or as I said, or as needed, the 20 milligram Cialis. So 5 milligram Cialis is taken on a regular basis, as opposed to the as needed 20 milligram dose. Side effects are common with these agents: flushing, nasal congestion, headache, vision changes, pain, back pain, diarrhea, dizziness. Just to know that they're not ongoing long-term side effects. They're just active during the active phase of the medication. And they make a little sense in that PDE5 inhibitors are vasodilators. So wherever have small blood vessels, they'll dilate. We have small blood vessels in the face, so they'll dilate and the blood will come to the surface. That's the flushing, and the heat or warmth will feel. Small blood vessels in our nasal passage can cause headaches and congestion. Vision changes, small blood vessels, and actually different receptors related to the PDE5 or PDE inhibitors. The one most commonly discussed is that Viagra can sometimes create a little bit of a blue hue. Also, vision changes for the other ones is just a little bit of blurriness on the periphery. The evidence is that none of this is permanent. Sometimes you will also get back pain. And these side effects vary across men, certainly, for no apparent reason. And as well, they will differ in terms of level of dosage. So the higher the dose, if you have that side effect, the more you'll experience that side effect. There's the way they differ is of onset of action, side effect profile, and duration of effect. Although they have some side effect profile differences, they have a lot of common ones. So that's important to tease out. Different onset of action. Sendra is now considering to be a faster acting PDE5 inhibitor, and duration of effect is more known with Cialis. Cialis is known as the weekender. You take it on Friday, it's good through to the end of the weekend. This is more true for patients that have erectile dysfunction for other reasons than, for instance, a rhabdomyosarcoma prostatectomy. So be sure to talk to your physician who's prescribing these, so you get a good idea of what to expect. I recommend through our clinic, just as a method of kind of incorporating how do we introduce oral medications into our sex lives. And so I kind of break it down into the laboratory approach, and that's where you set your alarm for an hour to an hour and a half before you get up in the morning. Take your prescribed pill at the recommended dosage, hopefully fall back asleep for about an hour and a half. That allows full saturation of the medication. Wake up, empty your bladder, and then on your own, get yourself in a sexy state of mind, whatever can be useful in doing that. And then self-stimulate your genitals, much like you do during masturbation. And note the firmness of any erection achieved. If there's any increased blood flow, it means the nerves are functioning to some degree, and hopefully they will recover over time. Also note side effects. The rationale behind this is that obviously in the morning, there's no food or alcohol in your system. These medications don't love the presence of food in digestion or alcohol. That's less true maybe for Cialis. You're well rested, and since you're on your own, there's no performance anxiety. This is a wonderful approach. If you want to, certainly include your partner in this process as well. That's the kind of laboratory approach, just to monitor how you are responding to the medication. And remembering, for instance, for a prostatectomy, if the nerves are disrupted during the process, it can easily take a year for some level of recovery in erectile function, and often 2 years. And so it's important that you don't have these overly strong expectations that the first time you pop the blue pill, it's going to work. Then sexual activity, lovemaking approach. This is just take the medication as directed, but attempt to adhere to an optimal response of the 1 hour's little food and alcohol, but then engage in sexual activity as you would normally, without the necessarily the desire or goal of penetrative sex. And this way you still get some activation of your erectile system with the medication. However, you're not so focused on it that it becomes like a laboratory as opposed to the warmth of the sexual activity. Engage in the sexual activity. You can be brought to orgasm, dry as it may be, with a fully flaccid penis. So you do not need an erection for that. And you can enjoy what some people call outer core, so non-penetrative based sexual activity. Another one is intraurethral suppository, or MUSE. This is a little microsuppository that you insert into the tip of your penis. It's moderately effective. It may cause some mild burning or throbbing sensation in the urethra. It's, if not fully absorbed by the body, by your body, it can affect the partner. In other words, it can leak into the partner and cause some reaction or blood flow in the genital area of your partner. And then less invasive than injections. And so often it's a stepping stone from PD5 inhibitors to injections. The vacuum device is quite effective. It's a little bit clumsy, and that's why it's hard on people. But so it's very important to involve your partner in this, that you're not doing this in the washroom and coming out, that it's part of your sexual repertoire, so to speak. You do need a ring in order to maintain the erection for a period of time to enjoy penetrative sex. However, that ring needs to be removed within 30 minutes in order to ensure that we restore blood flow, because you're just trapping blood flow in blood in the penis under the vacuum situation. So you need to let the blood flow back in. The penis can feel cool because there is no warm blood flow. And it may be firm but not erect. And that really refers to the fact where you put the ring is right at the base of the penis, but that doesn't allow necessarily for it to stand erect. So the penis is more likely to pivot, although be firm. And it's an excellent choice. And I often talk to patients and partners about the fact that if they do not want to engage in any medication, that it's a non-medication based approach. Penile injections are also important. It's the idea that bark is worse than its bite, very effective, but and the bark is worse than bite, meaning that it sounds very challenging to inject your penis. Remember, it's a small gauge penis, or sorry, small gauge needle, not unlike one that would be used for the flu shot. And it's painful, yes, just like it's painful when for a brief moment when you have an injection in your arm, but beyond that, most patients say it's not painful. And it takes about 15 minutes to work. It's 90+% effective. It's just a little bit of a challenge on how to incorporate it in your regular sex life. I often suggest to patients and partners, if they're engaging in sexual activity 4 times a month, you might want to just engage in non-penetrative sex 3 times a month and bring each other to orgasm if that's the goal, and enjoy each other. But if you want to then experience the penetrative sex, use an injection once a month, and that will allow for that re-experience of penetrative sex. So you can mix it together whichever way makes sense, but it's often helpful to recognize that every time you engage in sexual activity doesn't mean you have to have an injection. Then there's penile prosthesis. There are two main types of penile implants, semi-rigid or inflatable. These are options of the last resort, people will say. So I put a question mark there. That's not necessarily the case for everybody. We have to go with the values of what's important to individuals involved, but it certainly makes some sense to try the less invasive ones before we get to a prosthesis. As noted, there are the differing types, and it's semi-rigid and inflatable, and then sometimes there's 3-stage versus 2-stage. So it's important to have a good discussion with the surgeon before choosing. And in the literature, those that have actually undergone the procedure, the penile, do have very high satisfaction rates in the 85% plus range. Little humor, the Viagra switch, if the light stays on for more than 4 hours, call your electrician.